Firstly, thank you very much for inviting me to speak here at this very exciting Congress, the 9th World Congress for Teledermatology. And it's a privilege to be involved and also to listen and learn from our international colleagues as to their experiences and how to drive forward this exciting, new and innovative way of delivering dermatology care in a modern world. Regarding conflicts of interest, I do have a significant conflict of interest to declare in that I am a co-founder and co-owner of Dermview Limited, which is an Irish-based teledermatology and teledermoscopy managed platform service. So, in my view, why is dermoscopy important and why should we have it embedded and as an integral part of a high-quality teledermatology service? Well, it's not just my opinion or opinion of other clinicians, but it's also evidence-based. And if we look to the Cochrane database, and they did a review in early December 2018, and looked basically at the studies which are out there in the literature, looking at how accurate is dermoscopy compared to visual inspection of the skin for diagnosis of skin cancer, in this case melanoma, in adults. So they identified 104 studies, which accounted for nearly just under 43,000 skin lesions. And they did two different types of analysis. The first was a meta-analysis of data from 26 in-person studies comparing in-person visual inspection plus dermoscopy versus 13 in-person visual inspection studies alone. And the result of that, what the meta-analysis found that with usage of dermoscopy, there was a four-fold greater increase in accuracy of diagnosis compared to using just visual inspection alone of the pigmented lesion. They also looked at 60 image-based dermoscopy studies versus 11 image-based visual inspection studies. These were not in-person studies, but remote studies. And they found that dermatoscopic images, when they were used, were 5 times more accurate in diagnosis of a melanoma from a pigmented lesion. So there is a good evidence base to show that dermoscopy, high quality dermoscopy, is an integral and crucial part of a teledermatology service. So they concluded by showing that dermoscopy usage increased the detection of melanoma by at least 20%, and nearly as importantly, in such a setting of limited resources that we all have, dermoscopy usage also reduced the number of lesions that were incorrectly diagnosed as malignant melanoma by up to 500%, which means there was a 5-fold decrease in the number of benign lesions that were being removed. The caveat to all that, and which we all know as clinicians, is that dermoscopy is most useful and really should be used, and it's a useful clinical tool in an experienced clinician and dermoscopist's hands. So I suppose stepping back a bit, why do we need a high quality teledermatology, teledermoscopy service? And I know I'm speaking to the converted already here, but still, why? If it's good for us just think back on this. Well, if we look at this is a slide borrowed from Dermview, but the current patient or user experience of their clinical journey, their clinical pathway, is a multi-step process. And depending on the actual environment that we work in, wherever the jurisdiction is, this whole process could be anything from a couple of months to even a couple of years. So this traditional model of dermatology care is really, in my view, unfit for purpose. Added to this is the fact that the knowledge base of the referring practitioner hospital, through no fault of their own, but just because unfortunately in most of our medical schools, dermatology isn't something that's very high up the agenda to be taught. So I looked at 100 referrals to my public practice. These are all lesional referrals, query skin cancers. A third of these were said to be urgent by the referring doctor, but by my interpretation of the written traditional description of presenting complaint, only a third of those I actually thought were truly urgent. And equally as worrying, of the 2/3 who the GP thought was routine, at least 10% of those were actually urgent in my view. So the whole triaging process, the traditional triaging process of dermatology referrals, there's a discorrelation between what the GP and the referring doctor is trying to tell me or tell the specialist and how we interpret that. And as we have only a very small finite number of clinic spaces to give, this means that there's a huge amount of wastage of our important and resource limited clinical space. So I suppose just as an example of that, this type of a written presenting complaint, as you see here, keratotic plaque on the left side of the face, it could actually describe any one of the 4 following clinical scenarios. It's obvious to all of us that the only case that needs to be seen urgently is this chap here who has an SCC and which needs to come in for urgent surgery. All when the GP does often of quite a low quality. These are 3 examples that were sent by GPs in my local area who have a special interest in dermatology, but either they're out of focus, and I remember the GP referring doctor said, the picture will be of great help to you, it's of no help, or it's obscured by shadowing, or even when it is a good quality photograph, it's in black and white. Now, dermoscopy, as with all clinical skills, there is a learning phase and there are problems. It can be due to poor focus, as in this case. It can be due to the dermatoscopic pigmentary detail being obscured by surface changes, such as dryness of the skin in this case, where the dermoscopist didn't realize that it would have been better if we put on a little bit of paraffin just to wet the area so we could see the pigmentary detail. Or it could be that the dermatoscopic detail of this papule here is being obscured by cosmetics. So it is important that the dermoscopist is trained, whether this be an advanced nurse practitioner or indeed the doctor himself. Dermatoscopic features also can be obscured by body hair, as in this case. But coming back to this previous slide, why is dermoscopy important? Because it can increase the melanoma detection by at least 20%, and on average from the studies about 24-25%, and it can greatly reduce the such wasted use of resource where benign lesions are removed through a lack of dermoscopy or lack of proper dermatoscopic interpretation. But the caveat again is that dermoscopy, we need to be spending more and more time training our colleagues, either our dermatological colleagues who don't yet use it, or those referring doctors, so that they're comfortable and know how to use it properly. But when it is used properly, we can see that it can be of great help. And although this looks quite a benign lesion, and certainly to the macroscopic appearance it probably is, the patient was extremely worried as a referring doctor, but we can see the nice cerebriform dermatoscopic appearance telling us it is indeed just a benign seborrheic keratosis. And similarly, a rapidly growing nodule on the lower abdomen, we can see with good dermoscopy that again it is just a benign irritated mole. Dermoscopy can also be very useful, as we know, and especially in a teledermatology setting, when there is need to be examination and a referral of a lesion in a crucial centrofacial area, such as the nasojugal area here of the cheek, and again the dermoscopy showing features suggestive of a benign seborrheic keratosis. Teledermatology can also be extremely useful in a pediatric population. This is a young 6-year-old whose parents and the referring doctor were very concerned about this new mole which had developed. But again, the dermoscopy is benign and we can reassure the patient, and especially in a pediatric setting, spare them having to have any surgery at such a young age. One of the common referrals into us as dermatologists is that of query subungual melanoma. And we've all seen this in our practice many times. But a high quality teledermatology and teledermoscopy platform can actually obviate and mean that there's no necessity for this patient to even come through to our clinic. We can reassure them remotely. As we can see here on the high quality macroscopic photos, that there is no evidence of Hutchinson sign, and then up close on dermoscopy, we can see the pigment changes suggestive of hemorrhage. Similarly, a high-quality teledermoscopy service can be used to follow a possibly suspicious subungual pigmentation serially. And this is the initial presentation where the patient was adamant that there be no history of any previous trauma. There is some subungual hyperkeratotic area here, suggestive of possible onychomycotic involvement. But then when we see the serial photo taken 3 months later, there's normal proximal nail plate growing out here proximally, and we can reassure the patient. And again, they are spared the necessity of having to come to the hospital for a visit and assessment. But of course, the main clinical strength of a high-quality teledermoscopy service is that it can pick out those moles and pigmented lesions that are suspicious, either being dysplastic in this case, or obviously in case they're a melanoma. Now, obviously, when you have a case like this, where it's so obvious from the macroscopic picture, you don't need a teledermoscopy picture. But it is important, and it shows you the benefit of having teledermatology, whereas, you know, the written description, depending on the referring GP, could, it could be quite variable as to how that's described. So obviously, once you see that picture, then the patient is brought in that week for surgery. High quality teledermoscopy, though, can also reaffirm and confirm one's clinical suspicion from the macroscopic picture that this is indeed a superficial spreading melanoma, in this case of a Breslau depth of 0.5 millimeters. High quality teledermoscopy can also be of great use. This is a patient who came through our teledermoscopy and teledermatology platform and usage, and she used her service, and she was actually totally not worried at all about this lesion, but it was one of 5 or 6 lesions that we photographed on the day, and then again with the irregular moth-eaten border and the asymmetry of the lesion, this was excised and again showed to be a melanoma 0.6 millimeters. A high quality teledermoscopy service can also be of use to try and get early intervention in the management of new pigmented lesions. This is a gentleman in his early 70s who over the previous couple of years has developed this, again was pretty nonplussed by it and not really too concerned, accessed our service, and for me it has a standout macroscopic appearance, and then although not terribly worrisome with regard to the dermoscopic detail, it shows enough for me to be concerned that this I thought was probably going to be Untitled maligna, and indeed turned out to be a melanoma in situ. So again, this gentleman was delighted, as in our setting currently, he would have been waiting many months for this to be reviewed through the traditional referral model. And in this case, he ended up having his surgery within 2 weeks of having his actual teledermoscopy assessment. So it can allow early intervention in these cases, which we all know. We just need to see, can we spread the word to our colleagues out in the community. For me, as a Mohs surgeon, I find the use of the dermoscopy and the teledermoscopy very useful. So I know this is an obvious basal cell carcinoma, but I can also look with regard to the dermatoscopic subclinical spread of the tumor, how extensive the surgery is likely to be, and then what type of repair I'll need to initiate. So I can have a lot of my preoperative assessment done with the patient before I even meet them on the day of surgery. A high quality teledermoscopy system can also allow for the accurate diagnosis and picking up of a tumor that otherwise may not be seen. Here we have this erythematous linear patch on the right mid jawline, which on dermoscopy we can see the arborizing vessels. So this was indeed a basal cell carcinoma, but had thought to be just actinic damage by the referring doctor. High quality teledermatology and teledermoscopy service can also be used not just in malignant and query malignant conditions, as in skin cancer, but also inflammatory dermatosis, such as this young lady with discoid lupus. So in our experience, the high quality teledermatology teledermoscopy system has changed the model of care and the delivery of care, so that instead of every patient who's referred to us having to come into the hospital setting and be seen physically, with the high quality system, we actually now can triage the patients on a medical need rather than a chronological time basis as it is currently. And we found that only about 35 to 45% of the patients that are referred to us now, we actually need to see in the hospital. So this has greatly sped up treatment times for us. So in summary, as we all know, teledermatology is an exciting, proven model of dermatology care. And in my opinion, teledermoscopy greatly enhances this power and utility of teledermatology. And it is important that the teledermoscopy equipment and service that we use is of high quality to optimize the image results. The caveat, but which we know, is that dermoscopic proficiency and experience is essential. So thank you very much for inviting me to talk. And I'm looking forward to talking to you and any points you may have about your experience of using teledermoscopy in your jurisdiction, and as we try and push forward this whole innovative model of dermatology care in teledermatology. Thank you.